Breastfeeding, variously known as chest feeding or nursing, is the process where breast milk is fed to a child. Breast milk may be from the breast, or may be pumped and fed to the infant. The World Health Organization, WHO, recommend that breastfeeding begin within the first hour of a baby's birth and continue as the baby wants. Health organizations, including the WHO, recommend breastfeeding exclusively for 6 months. This means that no other foods or drinks, other than vitamin D, are typically given. The WHO recommends exclusive breastfeeding for the first 6 months of life, followed by continued breastfeeding with appropriate complementary foods for up to 2 years and beyond. Of the 135 million babies born every year, only 42% are breastfed within the first hour of life. Only 38% of mothers practice exclusive breastfeeding during the first 6 months, and 58% of mothers continue breastfeeding up to the age of 2 years and beyond. Breastfeeding has a number of benefits to both mother and baby that infant formula lacks. Increased breastfeeding to near universal levels in low and medium income countries could prevent approximately 820,000 deaths of children under the age of 5 annually. Breastfeeding decreases the risk of respiratory tract infections, ear infections, sudden infant death syndrome, SIDS, and diarrhea for the baby, both in developing and developed countries. Other benefits have been proposed to include lower risks of asthma, food allergies, and diabetes. Breastfeeding may also improve cognitive development and decrease the risk of obesity in adulthood. Benefits for the mother include less blood loss following delivery, better contraction of the uterus, and a decreased risk of postpartum depression. Breastfeeding delays the return of menstruation, and in very specific circumstances, fertility, a phenomenon known as lactational amenorrhea. Long-term benefits for the mother include decreased risk of breast cancer, cardiovascular disease, diabetes, metabolic syndrome, and rheumatoid arthritis. Breastfeeding is less expensive than infant formula, but its impact on mothers' ability to earn an income is not usually factored into calculations comparing the two feeding methods. It is also common for women to experience generally manageable symptoms such as vaginal dryness, Decatur vein syndrome, cramping, mastitis, moderate to severe nipple pain, and a general lack of bodily autonomy. These symptoms generally peak at the start of breastfeeding but disappear or become considerably more manageable after the first few weeks. Feedings may last as long as 30 to 60 minutes each as milk supply develops and the infant learns the suck-swallow-breathe pattern. However, as milk supply increases and the infant becomes more efficient at feeding, the duration of feeds may shorten. Older children may feed less often. When direct breastfeeding is not possible, expressing or pumping to empty the breasts can help mothers avoid plugged milk ducts and breast infection, maintain their milk supply, resolve engorgement, and provide milk to be fed to their infant at a later time. Medical conditions that do not allow breastfeeding are rare. Mothers who take certain recreational drugs should not breastfeed. However, most medications are compatible with breastfeeding. Current evidence indicates that it is unlikely that COVID-19 can be transmitted through breast milk. Smoking tobacco and consuming limited amounts of alcohol and/or coffee are not reasons to avoid breastfeeding. Breast development starts in puberty with the growth of ducts, fat cells, and connective tissue. The ultimate size of the breasts is determined by the number of fat cells. The size of the breast is not related to a mother's breastfeeding capability or the volume of milk she will produce. The process of milk production, termed lactogenesis, occurs in 3 stages. The first stage takes place during pregnancy, allowing for the development of the breast and production of colostrum, the thick, early form of milk that is low in volume, but rich in nutrition. The birth of the baby and the placenta triggers the onset of the second stage of milk production, triggering the milk to come in over the next several days. The third stage of milk production occurs gradually over several weeks, and is characterized by a full milk supply that is regulated locally, at the breast, predominantly by the infant's demand for food. This differs from the second stage of lactogenesis, which is regulated centrally, in the brain, by hormone feedback loops that naturally occur after the placenta is delivered. Although traditionally, lactation occurs following pregnancy, lactation may also be induced with hormone therapy and nipple stimulation in the absence of pregnancy. More information on this topic may be found in section 5.4, Induced Lactation. Lactogenesis I and other changes in pregnancy. Changes in pregnancy, starting around 16 weeks gestational age, prepare the breast for lactation. These changes, collectively known as lactogenesis I, are directed by hormones produced by the placenta and the brain, namely estrogen, progesterone, prolactin, which gradually increase throughout the pregnancy, and result in the structural development of the alveolar, milk-producing, tissue and the production of colostrum. While prolactin is the predominant hormone in milk production, progesterone, which is at high levels during pregnancy, blocks the prolactin receptors in the breast, thus inhibiting milk from coming in during pregnancy. Many other physiologic changes occur under the control of progesterone and estrogen. These changes include, but are not limited to, dilation of blood vessels, increased blood flow to the uterus, increased availability of glucose, which subsequently is passed through the placenta to the fetus, and increased skin pigmentation, which results in darkening of the nipples and areola, formation of the linea nigra, and onset of melasma of pregnancy. Lactogenesis II. The third stage of labor describes the period between the birth of the baby and the delivery of the placenta, which normally lasts less than 30 minutes. The delivery of the placenta causes an abrupt drop-off of placental hormones. This drop, specifically in progesterone, allows prolactin to work effectively at its receptors in the breast, leading to an array of changes over the next several days that allow the milk to come in. These changes are known collectively as lactogenesis II. Colostrum continues to be produced for these next few days, as lactogenesis II occurs. Milk may come in as late as 5 days after delivery, however, this process may be delayed due to a number of factors as described in the process delay in milk coming in subsection below. Oxytocin, which signals the smooth muscle of the uterus to contract during pregnancy, labor, birth, and following delivery, is also involved in the process of breastfeeding. Oxytocin also contracts the smooth muscle layer of band-like cells surrounding the milk ducts and alveoli to S the newly produced milk through the duct system and out through the nipple. This process is known as the milk ejection reflex, or letdown. Because of oxytocin's dual activity at the breast and the uterus, breastfeeding mothers may also experience uterine cramping at the time of breastfeeding, for the first several days to weeks. Lactogenesis III. Prolactin and oxytocin are vital for establishing milk supply initially, however, once the milk supply is well established, the volume and content of the milk produced is controlled locally. Although prolactin levels are higher on average among breastfeeding mothers, prolactin levels themselves do not correlate to milk volume. At this stage, production of milk is triggered by milk drainage from the breasts. The only way to maintain milk supply is to drain the breasts frequently. Infrequent or incomplete drainage of the breasts decreases blood flow to the alveoli and signals the milk-producing cells to produce less milk. The pattern of intended nutrient content in breast milk is relatively consistent. Breast milk is made from nutrients in the mother's bloodstream and bodily stores. It has an optimal balance of fat, sugar, water, and protein that is needed for a baby's age-appropriate growth and development. That being said, a variety of factors can influence the nutritional makeup of breast milk, including gestational age, age of infant, maternal age, maternal smoking, and nutritional needs of the infant. The first type of milk produced is called colostrum. The volume of colostrum produced during each feeding is appropriate for the size of the newborn stomach and is sufficient, calorically, for feeding a newborn during the first few days of life. Produced during pregnancy and the first days after childbirth, colostrum is rich in protein and vitamins A, B12 and K, which supports infants' growth, brain development, vision, immune systems, red blood cells, and clotting cascade. The breast milk also has long-chain polyunsaturated fatty acids which help with normal retinal and neural development. The caloric content of colostrum is about 54 calories/100 ml. The second type of milk is transitional milk, which is produced during the transition from colostrum to mature breast milk. As the breast milk matures over the course to several weeks, the protein content of the milk decreases on average. The caloric content of breast milk is reflective of the caloric requirements of the infant, increasing steadily after 12 months. The caloric content of breast milk in the first 12 months of breastfeeding is approximated to be 58 to 72 calories/100 ml. Comparatively, the caloric content after 48 months is approximately 83 to 129 calories/100 ml. When a mother has her full milk supply and is feeding her infant, the first milk to be expressed is called the foremilk. Foremilk is typically thinner and less rich in calories. The hind milk that follows is rich in calories and fat. If the mother is not herself deficient in vitamins, breast milk normally supplies her baby's needs, with the exception of vitamin D. The CDC, National Health Service, UK, Canadian Pediatric Society, the American Academy of Pediatrics, and the American Academy of Family Physicians all agree that breast milk alone does not provide infants with an adequate amount of vitamin D, thus they advise parents to supplement their infants with 400 IU vitamin D daily. 40, 41, 42, 43, 44, 45 Providing this quantity of vitamin D to breastfeeding infants has been shown to reduce rates of vitamin D insufficiency, defined as 25O vitamin D 15 mol/L. However, there was insufficient evidence in the most recent Cochrane review, to determine if this quantity reduced rates of vitamin D deficiency, defined as 25O vitamin D 13 mol/L, or rickets. 46-term infants typically do not need iron supplementation. Delaying clamping of the cord at birth for at least 1 minute improves the infant's iron status for the first year. When complementary, solid, foods are introduced at about 6 months of age, parents should make sure to choose iron-rich foods to help maintain their children's iron stores. In addition to the nutritional benefits of breast milk also provides enzymes, antibodies, and other substances that support the infant's growth and development. The bioactive makeup of breast milk also changes based on the needs of the infant. For example, when an infant is recovering from an upper respiratory infection, local signaling allows for increased passage of immune cells and proteins to aid the infant's immune system. Produced during pregnancy and the first days after childbirth, colostrum is easy to digest and has laxative properties that help the infant to pass early stools. This aids in the excretion of excess bilirubin, which helps to prevent jaundice. Colostrum also helps to seal the infant's gastrointestinal tract from foreign substances and germs, which may sensitize the baby to foods that the mother has eaten and decrease the risk of diarrheal illness. Although the baby has received some antibodies, IgG, through the placenta, colostrum contains a substance which is new to the newborn, secretory immunoglobulin A, IgA. IgA works to attack germs in the mucous membranes of the throat, lungs, and intestines, which are most likely to come under attack from germs. Additionally, colostrum and mature breast milk contain many antioxidant and anti-inflammatory enzymes and proteins that decrease the risk of gastrointestinal allergies to food, respiratory allergies to air particles like pollen, and other atopic diseases, such as asthma and eczema. It is recommended for mothers to initiate breastfeeding within the first hour after birth. Uninterrupted skin-to-skin contact and breastfeeding can begin immediately after birth, and should continue for at least 1 hour after birth. This period of infant-mother interaction, known generally as kangaroo care, or the golden hour during the immediate postpartum period, assists in the mother-child bonding for both mother and baby, and is thought to encourage instinctual breastfeeding behavior in the infant. Newborns who are immediately placed on their mother's skin have a natural instinct to latch onto the breast and start nursing, typically within 1 hour of birth. Success with breastfeeding in this golden hour increases the likelihood of successful breastfeeding at discharge. Skin-to-skin mother-baby contact should still occur, even if the baby is born by cesarean surgery. The baby is placed on the mother in the operating room or the recovery area. If the mother is unable to immediately hold the baby, a family member can provide skin-to-skin care until the mother is able. According to studies cited by UNICEF, babies naturally follow a process which leads to a first breastfeed. Shortly after birth, the infant relaxes and makes small movements of the arms, shoulders, and head. If placed on the mother's abdomen, the baby gradually inches towards the breast, called the breast crawl, and begins to feed. After feeding, it is normal for a baby to remain latched to the breast while resting. This is sometimes mistaken for lack of appetite. Absent interruptions, all babies follow this process. Rushing, by picking up and moving the infant to the breast, or interrupting the process, such as removing the baby to weigh him/her, may complicate subsequent feeding. Activities such as weighing, measuring, bathing, needle sticks, and eye prophylaxis wait until after the first feeding. Children who are born preterm, before 37 weeks, children born in the early term period, 37 weeks, 38 weeks and 6 days, and children born with low muscular tone, such as those with chromosomal abnormalities like Down syndrome or neurological conditions like cerebral palsy, may have difficulty in initiating breastfeeds immediately after birth. These late preterm, 34 weeks, 36 weeks and 6 days, and early term, 37 weeks, 38 weeks and 6 days, infants are at increased risk for both breastfeeding cessation and complications of insufficient milk intake, example dehydration, hypoglycemia, jaundice, and excessive weight loss. They are often expected to feed like term babies, but they have less strength and stamina to feed adequately. By convention, such children are often fed on expressed breast milk or other supplementary feeds through tubes, supplemental nursing systems, bottles, spoons or cups until they develop satisfactory ability to suck and swallow breast milk. Regardless of feeding method chosen, human milk feedings, whether from the mother or a donor, are important in the brain development of premature infants, and the NICU having a standardized protocol for feeding is protective against dangerous gastrointestinal infections, necrotizing enterocolitis, in these infants. Frequent breastfeeding and/or small amounts of supplementation may be needed for successful outcomes. Breast pumping and/or hand expression is often helpful in providing adequate stimulation to the mother's breasts. Starting to breastfeed may be challenging for mothers of preterm infants, especially those born before 34 weeks, because their breasts may still be developing. In lactogenesis I, see breastfeeding physiology. Additionally, mother-infant separation and the stressful environment of the NICU are also barriers to breastfeeding. Availability of a lactation specialist in the NICU can be helpful for mothers trying to establish their milk supply. Additionally, skin-to-skin, kangaroo care, has been shown to be safe and beneficial to both mother and baby. Care stabilizes newborn premature infants' vital signs, such as their heart rate, providing a naturally warm environment that helps them regulate their temperature. It is also beneficial to the mother, as it may improve the development of her milk supply and be beneficial for her mental health. Newborn babies usually breastfeed 8 to 12 times every 24 hours, and they typically express hunger cues every 1 to 3 hours for the first 2 to 4 weeks of their lives. A newborn has a small stomach capacity, approximately 20 ml. The amount of breast milk that is produced is timed to meet the infant's needs in that the first milk, colostrum, is concentrated but produced in only very small amounts, gradually increasing in volume to meet the expanding size of the infant's stomach capacity. Many newborns will typically feed for 10 to 15 minutes on each breast, however feeds may last up to 45 minutes depending on infant wakefulness and efficiency. It is important for parents to recognize the difference between nutritive and non-nutritive sucking. Nutritive sucking follows a slow, rhythmic pattern, with 1 to 2 sucks per swallow. Non-nutritive sucking is a faster-paced sucking pattern with few swallows. This swallow pattern is often observed at the beginning and/or the end of a feed. At the beginning of the feed, This pattern triggers milk letdown, while at the end of the feed, this may be a signal of the infant tired or becoming relaxed with a slower milk velocity. Numerous health organizations, including, but not limited to, the CDC, WHO, National Health Service, Canadian Pediatric Society, American Academy of Pediatrics, and American Academy of Family Physicians, recommend breastfeeding exclusively for 6 months following birth, unless medically contraindicated. Exclusive breastfeeding is defined as an infant's consumption of human milk with no supplementation of any type, no water, no juice, no non-human milk, and no foods, except for vitamins, minerals, and medications. Supplementation with human donor breast milk may be indicated in some specific cases, as discussed below. After solids are introduced at around 6 months of age, continued breastfeeding is recommended. The American Academy of Pediatrics recommends that babies be breastfed at least until 12 months, or longer if both the mother and child wish. The World Health Organization's guidelines recommend continued frequent, on-demand breastfeeding until 2 years of age or beyond. Extended breastfeeding means breastfeeding after the age of 12 or 24 months, depending on the source. In Western countries such as the United States, Canada, and Great Britain, extended breastfeeding is relatively uncommon and can provoke criticism. In the United States, 22.4% of babies are breastfed for 12 months, the minimum amount of time advised by the American Academy of Pediatrics. In India, mothers commonly breastfeed for 2 to 3 years. Supplementation is defined as the use of additional milk or fluid products to feed an infant, in addition to breast milk, during the first 6 months of life. The Academy of Breastfeeding Medicine recommends only supplementing when medically indicated, as opposed to mixing use of formula and breast milk for reasons that are not necessarily medical indications. Some medical indications for supplementation include low blood sugar, dehydration, excessive weight loss or poor gain, and jaundice in the infant, true low milk supply, severe nipple pain unrelieved by interventions, and medical contraindications to breastfeeding, as described below. Supplements can be delivered at the breast through a supplemental nursing system in order to stimulate the production of the mother's own milk and to preserve the breastfeeding relationship. Some parents may desire to supplement proactively if early signs of insufficient intake, such as decreased urination, dry mucous membranes, or persistent signs of hunger, are noticed. If these signs are noticed, it is important to have the mother-infant dyad evaluated by a breastfeeding specialist or pediatrician to determine the true cause of the symptoms and determine the need for supplementation. Often, these symptoms are caused by poor milk transfer at the breast, and can be solved with adjustments to the latch, but occasionally they may be caused by other processes, unrelated to breastfeeding, so evaluation is necessary. Supplementation with formula is associated with decreased rates of exclusive breastfeeding at 6 months, and overall decreased length of breastfeeding. In terms of what to supplement with, the first choice is always the mother's own breast milk, save any medical contraindications to its use. The second best option for supplementation is pasteurized human donor milk. Finally, specific formulas may be used for supplementation if maternal or donor breast milk are not options. One situation where this may be the case is in cases of infant metabolic diseases, such as galactosemia. The Academy of Breastfeeding Medicine recommends that supplementation only be used when medically indicated and when overseen by a medical professional, such as a pediatrician or family physician, and after consultation with an IBCLC. Without sufficient breast stimulation, supplementation can reduce the mother's milk production, so pumping would be indicated in these cases if continued breastfeeding is desired. Indications for use of donor breast milk are very closely outlined by the American Academy of Pediatrics, AAP. Due to low availability and high cost of donor breast milk, the AAP recommends prioritizing the use of the milk for infants born with a weight of less than 1500 g, approximately 3 pounds 5 ounces, as it is helpful in decreasing rates of the severe intestinal infection, necrotizing enterocolitis, in this population. Effective positioning and technique for latching on are necessary to prevent nipple soreness and allow the baby to obtain enough milk. Babies can successfully latch onto the breast from multiple positions. Each baby may prefer a particular position. The football hold places the baby's legs next to the mother's side with the baby facing the mother. Using the cradle or crossbody hold, the mother supports the baby's head in the crook of her arm. The crossover hold is similar to the cradle hold, except that the mother supports the baby's head with the opposite hand. The mother may choose a reclining position on her back or side with the baby lying next to her. No matter the position the parent-infant dyad finds most comfortable, there are a few components of every position which will help facilitate a successful latch. One key component is maternal comfort. The mother should be comfortable while breastfeeding, and should have her back, feet, and arms supported with pillows as necessary. Additionally, when starting the latch process, the infant should be aligned with their abdomen facing their mother, which can be remembered as tummy to mummy, and with their hips, shoulders, and head aligned. Thank you for watching this video.